Hello, welcome to our TIF Talk today. It's my pleasure today to introduce you to Dr. Chris Cottrell. He is an MD, FACS, and he is a general and minimally invasive robotic surgeon in McKinney, Texas. In addition, I'd like to welcome Lori Thomas, and she is one of Dr. Cottrell's patients. So welcome to the both of you to our TIF Talk today. So
Yeah,
you're welcome. Thank you. My name is Andrea Millers, and I'm with Endogastric Solutions. Thank you for joining us today for our TIF Talk Tuesday. Dr. Cottrell and Lori will be talking a little bit more about GERD and their symptoms, or GERD symptoms, and the TIF procedure. So let's just go ahead and start. Dr. Cottrell, maybe you can kind of give us a little bit more of a scientific explanation, or what is GERD? What is the description of GERD and GERD symptoms?
well, GERD is traditionally gastroesophageal reflux disease. That's what the acronym stands for. But specifically, scientifically, it is when gastric contents reflux up into the esophagus. And the symptoms that you feel is what people often describe as heartburn, or sometimes regurgitation, or that sort of sensation in the back of the throat, things like that. But specifically, it's a breakdown of the natural mechanism that prevents that, causing the stomach contents to come up.
Right. Okay. And what types of symptoms can patients feel if they're having GERD symptoms?
Yeah, it spans the gamut. Traditionally, heartburn, right? A feeling of sort of burning in the chest is pretty common, especially after spicy foods, hot foods, things like that. But there's a lot of sort of non-traditional symptoms as well. And you'll have people that said they've never, ever had heartburn that actually have severe reflux. So that can sort of look more like coughing, or sometimes even as far as choking, recurrent pneumonias, difficulty or painful swallowing. Some people kind of describe it more vaguely of just indigestion, and you kind of gotta tease that out as you're interviewing patients and discussing their symptoms as to kind of what they're actually feeling. Sometimes it's really, really easy, and sometimes you gotta dig a little bit, but that's kind of the fun.
Yeah. So Lori, maybe you can kind of tell us what types of symptoms that you had. How long ago were you diagnosed with GERD, if you will?
Oh, I don't remember exactly when the diagnosis was, but I've had the issue for probably 25 years.
Wow.
Most of my life.
Okay.
I had most of that list. I had mainly, just indigestion, heartburn for quite a few years. And then it progressed into where I was having trouble sleeping at night. I'd have to get up because I'd feel like things were coming up into my throat. Then I did have a tightening of my esophagus to the point where I had trouble swallowing, things like me.
Okay.
So I had that taken care of. And then my last that finally drove me in was asphyxiating acid into my lungs. Not asphyxiating, aspirating.
Okay. So were you diagnosed with GERD from your general practitioner, and were you on PPP Eyes? How did that? What were you doing?
I was on PPP Eyes for the esophagus. I had, like I said, had that stretched.
Sure.
Mainly just, I guess, self-medication with lots and lots of Tums, sleeping, in as upright a position as I could, trying to avoid doctors. Didn't work very well.
Uh-oh, we don't want you to avoid doctors. So did you have the TIF procedure?
About a year ago.
Okay, about a year ago. All right. Dr. Cottrell, what do you normally prescribe patients to do to help alleviate or manage GERD symptoms, prior to coming to you and having a surgical treatment option?
Right. Well, there's kind of two parts to that answer. Part one is being someone that surgically treats reflux. Typically, when someone that comes to me, they're ready to kind of move on from more of the simpler approaches. And so not unlike where Lori was, where she's just done and finally willing to brave to see a doctor, then so I don't deal with sort of the initial sort of presentation as much, but having done that sort of in the past, you know, a lot of times diet modification can help quite a bit. You can, you know, if you're just now starting to experience some symptoms, simple things like not eating too late can help with nighttime symptoms because the reflux gets worse when you lay down. So that's helpful. Eating earlier at night, sleeping in a more upright position, whether it be a chair or an adjustable bed, that can help. On pillows, that can help. Losing some weight, when we talk about kind of some of the mechanisms, having increased abdominal pressure in the form of obesity or weight can make reflux worse. So if you've recently gained weight and then you lose a little, and then you start having the reflux, then losing some may kind of put you back to a more comfortable position. So that's some of the simpler stuff. And there's foods to avoid as well, acid foods like you know, tomato-based products, lemonade, alcohol, coffee, tomato, you know, the stuff people like.
Right.
And so that's sometimes easier to do for some patients and sometimes a little tougher to do depending on their diet history. But then when it comes time and that's not really working, or, you know, we see reflux in people that are in absolute perfect physical specimens and they are eating very, very healthily, then it might be time to initially at least try medications. And so a short course of proton pump inhibitors, your Protonix, Prilosec, those types of things, you know, can be pretty beneficial to at least alleviate the symptoms. My concern has always been that you're just alleviating the symptoms, right? What we talked about earlier, when the heart burns, right? Heartburn, that's the symptom that you feel because you're experiencing reflux that happens to be acidic. So when you take a proton pump inhibitor, Protonix, Prilosec, whatever, then the stuff is no longer acidic, so it doesn't burn, but it still comes up. Right. So in Lori's case, for example, when things start to come up and you start to aspirate and start to develop pneumonia, your lungs don't care whether there's acid in it or not, you're still going to get a pneumonia. So symptoms alone, you know, great if it's short term and it kind of gets better, or you can do something else, but longer term, I feel like anatomical problems sort of need anatomical solutions.
Yeah, that's a very good point. Thank you for that. So let's talk a little bit about the different treatment options. Do you want to briefly discuss, you know, there was a Nissen a long time ago, or still people are doing Nissen depending on the patient, but there's other procedures as well. Do you want to talk a little bit more about what treatment options are available today?
Well, sure. So, I mean, we kind of just covered some of the medical therapies. There are some other things as well. There's besides proton pump inhibitors, there are H2 blockers, diet modification, weight loss. We talked about that.
Right.
So then once that's kind of broken down and the patient's either not doing well on medication or they don't want to take medication, and we might be talking about that a little bit later, then, you know, surgery may be an option for lots of patients. So traditionally, you know, 30, 40 years ago, an open surgery was done where we actually pulled the stomach into the correct location, reestablishing the anatomy, and then we had to suture the diaphragm, restore where the stomach is, and then wrap the stomach around the esophagus to create a valve. Pretty invasive, and frankly, that surgery wasn't done a whole lot, really only in what we would call end-stage reflux, where someone was just completely miserable, or severe recurrent aspiration pneumonias, things like that. In 1989, some of the first laparoscopic surgery started being done in France, brought to the United States around in the 1990s, I believe, and first kind of more with gallbladder type surgery, but then we started doing that with the Nissen. And then once we were able to do that with the Nissen, we started treating more people with reflux with that surgery. Then we sort of found out that while Nissen is a good surgery for reflux, it's aggressive in some ways, right? Because the way that the stomach gets wrapped around the esophagus, it can get a little tight. And as we age, certainly nothing ever gets better. So the esophagus doesn't contract as normally as it used to. And we started seeing that as people aged, they started having more problems swallowing or dysphagia. They also had more problems with what we call gas bloating, where things weren't going down very well, so they swallow more air. The air doesn't come up very easily because of the tight wrap, and you get this gas bloat situation. So the side effects were not great for treating just reflux without sort of more serious problems, right?
Right. Okay.
So now with a TIF procedure, which is kind of what we're talking about, it's an endoscopic approach. And the endoscopic approach allows for an internal wrapping of the stomach sort of around the esophagus in a similar way, but not as tightly, for a couple of reasons. But the most important, in my opinion, is the fact that the device itself acts as a dilator, so it just can't get too tight. Right. And you're not stretching the stomach, and there's not any problems with blood supply, and so you don't get any scarring or stricturing really either. So while short term, right after surgery, there are some diet modifications we need to do just while everything heals, but after 6 to 8 weeks, people return to normal food, and really those side effects historically and by data are minimal, if any. Right. And so you don't see that. And as we've gotten longer in this timeline of doing the TIF, the transoral incisionless fundoplication, then we're seeing that it's long lasting as well. When I first started doing this, I kind of thought, well, it's a really, really cool procedure. It might be of good benefit. And unlike a Nissen, it's easily repeatable. And so I kind of thought, well, if they got 5 years out of it and we had to redo it, okay, that might be beneficial. And my first patients, we really talked about that a lot, about that, hey, this is a little bit newer. We're going to do this. Studies look great. The side effect profile looks great. The safety profile looks great. But we don't know about the long term just yet. So what we found is the long term is excellent. While I can't say that I've never had to redo one, it's out of 300 or 400 cases or more now, I think we're looking at like 4 to 5. So I mean the redo recurrence rate is pretty low, and quite frankly, that's also, those patients were mostly patients kind of done very early in the experience. As we've gotten better at it, that's very, very rare.
Yeah. Exactly. It's actually the number's over 22,000 TIF procedures done in the U.S. Yeah. So you talked a little bit about PPP Eyes, and I wanted to ask Lori, you said you were on PPP Eyes. Were you getting concerned about being on PPP Eyes? Did it help with your symptoms, at least, when you were taking the PPP Eyes?
Yeah, I'd say it helped a little bit for a while.
Okay.
But pretty quickly it got to the point where it wasn't helping enough. And my dad actually has had a lot of these same symptoms, and he's had a lot of issues with being on PPP Eyes for a long time. So I was concerned that I would develop.
Right. And you had
Just a second. Yeah. Lori, I don't remember. Did you have relief of the heart? Was the other symptoms that really got you, or the heartburn didn't get controlled either?
No, it was controlled for a while, and then it seemed like it just sort of wore off, or it just wasn't doing enough good. And I continued to have heartburn, acidic feeling. Definitely.
Now and you had a unique situation, right? You were aspirating and you were getting pneumonia.
Correct.
From that. Okay. And so were you referred from your general practitioner to Dr. Cottrell? Okay. Yeah. And uniquely, you also had a hiatal hernia, correct?
Correct.
Okay. So maybe, let's ask this question first. Let's talk about PPP Eyes and long-term effects of PPP Eyes. What is your, Dr. Cottrell, do you want to talk a little bit about that?
Sure. It's an ongoing kind of, it's a developing story to a certain degree. There have been studies that have shown increased risk of cardiac mortality even. There was one study, I think, that showed an 18% increase, but there was some criticisms of the study. So that's a concern. Specifically, there's one of them, Protonix, I believe, actually interacts with some of the medications you might need after a heart procedure, for example. It interacts with some of the antiplatelet therapies. So you just can't be on stuff like that when you're on that medication, for example. So that's a concern. There's been some links to dementia and Alzheimer's disease. There's definitely some relationship with magnesium and calcium and how they're metabolized appropriately. The long-term effects of that, we're not entirely sure just yet. In addition, there's even been some association with renal failure. So there's kind of a myriad of things that long-term use may be associated with. It is a little bit difficult, and the data is kind of evolving as we speak, but it is a concern.
Right. Okay. Thank you. Let's talk a little bit about hiatal hernia repair and TIF. We do have a question here. Someone asking, can I get a hiatal hernia repair and a TIF together? Do you want to maybe discuss that
Sure.
a little bit?
Yeah, so let me kind of come back, because you had mentioned that Lori's case was unique, having a hiatal hernia, and realistically, I wanted to kind of, most patients that have severe reflux, and at least in my practice, the vast majority of patients that have reflux that are considering surgery also have a hiatal hernia. Right. The mechanism is such that the portion of the esophagus that lays below the diaphragm gets compressed by the positive pressure in the abdomen, and that is what prevents reflux. Okay, there's a little bit more to all that, but that's a pretty good simple explanation. In the office, I usually draw this on the whiteboard, but no whiteboard. So anyway, so basically when you have a hiatal hernia, that gets lifted up, sucked up really into the chest, such that that mechanism is no longer in place. So when we're repairing the hiatal hernia, we're restoring, that's what I mentioned earlier, that normal anatomy. So that prevents reflux by itself. Traditionally, going back kind of the history, if you repair a hiatal hernia by itself with 1950s or 60s technology, that eliminates reflux in 50% of patients. Mm-hmm. Now, it's 2020, so we have a lot more weapons, and with the TIF procedure combined with a better robotic hiatal hernia, then now we can take those numbers into the 90s or higher. So yeah, it's sort of an evolving process. Now, hiatal hernia repair. So can you have a TIF procedure with a hiatal hernia? Yes, that's been the majority of my practice the entire time, frankly. The TIF procedure by itself is a useful tool, but it really only is effective if you have a hernia less than 2 centimeters. Yeah. So if you have a hiatal hernia that's less than 2 centimeters, TIF works great. The data is beautiful, and 100%, you can do that all by itself, no incisions. It's amazing. If you have a hiatal hernia that's greater than 2 centimeters, what we can do is then we repair the hiatal hernia. Now it's less than 2 centimeters, and then we can go ahead and do the TIF. And the TIF, as compared to the Nissen, the side effect profile is so much better. It's worth the extra effort in the OR, because it actually takes an additional 45 minutes or so to break down the robot, get everything all set up, then do the TIF on top of that. But it's worth it just because the side effect profile is so much better and patients do so much better. Back when I did just Nissens by themselves, I mean, patients did well, but often it took them a long time to get to solid food. So commonly 2 to 3 months, at least in my hands, and then even a couple of patients that were 6 and 9 months before they really got to solid food. And a couple of those even had to be dilated. So that's just kind of the short term, and that doesn't even count sort of the long-term issues that sort of develop after a while.
Right. Okay. Thank you for clarifying that.
Sure.
That is absolutely true. So can you talk a little bit about the different diagnostic tests that a person would have to take to determine whether or not the TIF procedure is an appropriate treatment option for them?
For sure. The most important, honestly, is the patient interview, where we start. Hopefully, Lori will agree that when I saw her, we sit down, we talk for a while, and we really kind of go through the symptoms. We really chat, and sort of in doing that and piecing through with experience and data, I can tease out what's necessary and what's not necessary. I am not one that typically goes every single patient gets the exact same barrage of tests. We individualize it to the patient. That being said, we do obviously want to prove that reflux is a part of the thing. We usually can do that with a simple X-ray study called an upper GI. Patient drinks contrast, and then they take X-rays, and then they can just see whether or not there's reflux. They can also diagnose a hiatal hernia, although it tends to underestimate it. We can see a little bit of how well the esophagus contracts, and that can lead us to, do we need additional studies or not? If we have difficulty or the esophagus contracts poorly, we can kind of modify our approach, or they can get manometry studies, which is another GI test. If we don't see reflux on the upper GI, then a pH probe study can be very, very helpful. And then depending on the patient and how long they've had reflux, sometimes we do a scope beforehand. Sometimes we don't, because they get a scope that day. So, I'm not a big fan of repeating tests that we're doing already.
Right.
So yeah, I tend to be somewhat individually, sort of more rifle approach as opposed to shotgun. But that's just my approach. So I guess upper GI, pretty much everyone does get that, because they got to prove the reflux. And then beyond that, it's really tailored to what the patient interview and how what we see at that point.
That's great. Yeah, thank you very much. We do have a couple of questions from Facebook users, so I'm going to ask a couple of those questions. And again, if you are on live, please feel free to ask any questions. We'll do our best throughout the event and answer the questions. So this question is from Marianne. I think you kind of answered this. How long does a TIF procedure usually last, Dr. Cottrell?
So the TIF procedure by itself, I kind of did, because we talked about the robot and stuff. All by itself, the TIF procedure, we actually did one today, is from the time I put the scope in until the scope is gone and the patient's starting to wake up, is somewhere between 15 and 30 minutes. It's actually a very quick and easy procedure. It's really just a matter of the hernia adds like an extra 45 minutes to an hour. So true operative time ends up being an hour and a half, or hour and 5 minutes-ish for a simple hernia and TIF repair. But there's some setup, there's some breakdown in between, so the patient ends up being asleep for about an hour and a half.
Yeah, perfect. Okay. And then one other question from Allison. I take 2 PPIs a day. Is this the procedure for me?
Well, without conducting, obviously, an interview and physical exam, there's no way to know for sure. But if you're tired of your medication and you're not doing well on your medication, you're worried about some of the side effects that may develop from PPIs, then it's certainly something to consider, and at least consider the workup.
Yeah, perfect. So let's talk a little bit more about the TIF procedure. You did kind of go into an explanation, but maybe a little bit in more depth. What is a TIF procedure? Sure. How does it work? The mechanism of action, like, you know.
Sure. So the transoral incisionless fundoplication. Fundoplication is a big old $10 word for kind of wrapping the stomach around the esophagus, right? That part of the stomach we use is called the fundus. Fundoplication. Plication means to kind of put together. So sewing or putting the stomach around the esophagus is what a fundoplication is. So TIF, transoral incisionless fundoplication. So what it starts with is basically we put a scope down, we evaluate the stomach, we evaluate the esophagus, and we want to make sure everything's kind of healthy enough to undergo surgery. And then basically then there's a device that gets put down through the mouth, into the esophagus, and then into the stomach. The device itself, it kind of sort of folds like that. Mm-hmm. And at the fold, you can actually pull the junction of the esophagus and the stomach down, and then the device itself kind of clamps, and we can wrap internally, and then we fire fasteners. And I kind of always tell patients, they look like little tiny price tags. So they're little blue things. If you remember, a price tag is, it's got the little tiny piece and the little bar on the end. Well, this fastener has a bar on both ends, and it's a really cool device. It kind of fires out, and then it anchors both sides. So when we wrap, those anchors, fasteners, stay there. And then, so we wrap on one side, then we kind of wrap on the other, and then we sort of lengthen in the middle, and that creates a valve. And actually, I don't have a picture I can show, but it looks like the Greek letter omega, right? Just kind of does this sort of situation.
Right.
And effectively, you get somewhere between 270 to 300 degrees of wrap, which does a great job of controlling the reflux. It kind of creates a sort of a passive valve. Like sometimes talk about it's not the same thing as a flap valve like in your toilet bowl,
Yeah.
but it kind of does. It lets stuff in, but it's difficult for it to come back out.
Right. Thank you. That was great. Lori, how much did you know about the TIF procedure before you met Dr. Cottrell? Did you know anything about the TIF procedure? Okay. No. So he did a great job of explaining what it was and how it could work to you.
Yeah. All I knew from my GP was at this point I probably needed to look at surgery, and this is the guy. So that's what I did.
Fantastic. When you were learning about the TIF procedure, was there anything in particular that stood out to you as far as why this treatment option would work best for you?
I just wanted something permanent.
Yeah.
And I guess that the high numbers of success that was impressive. That it sounded like it was quick, easy, and good. So
fantastic.
It's working.
Lori, let me ask you. Now, a year out from it, does it seem quick and easy now?
Yeah, actually it does. If you had asked me 3 weeks afterwards, I might have said, I thought I'd be completely healed by now. And, but now I'm absolutely fine. So,
are there things, Lori, that you were not able to do prior to the TIF procedure? And I think you were saying the hardest part was sleeping at night. I think when we did a pre-interview. So
yes, sleeping and anything bending over, just bending over to pick up something off the floor.
Okay.
As soon as I tipped over, things came with it.
Oh gosh.
So, yeah.
So did you have to sleep with an incline on your bed, or did you?
I slept with several pillows, and we had a chair, a recliner in the room that I often used. I would get up and just sleep in the recliner.
Okay, so 1 year out, are you still sleeping in that recliner?
Oh, no. In fact, I sleep on. I have neck problems, so sleeping on an incline was not good for that. And now I sleep on one skinny little pillow, and that's it.
So, do you have any GERD symptoms anymore since your procedure, or has it?
No, I have very rarely, maybe once a month, a little. Indigestion. Before I had the procedure, I would take probably 4 Tums at a time.
Wow.
I'd take those, and 2 hours later, I'd take 4 more just to try to kick it. Now I can take 1 the few times I have issues, and we're done.
Yeah. And Dr. Cottrell, you could talk a little bit about that. I mean, people eventually, you sometimes will have acid reflux.
Well, I joke with patients a little bit sometimes, just kind of the way I am, I guess. But if you drink enough beer or eat enough pizza, you're gonna have reflux, right? I mean, there's limits to what we can accomplish. So typically, when someone has issues afterwards at all, which are kind of, Lori's a perfect example of once a month I take 1 Tums compared to all day, every day.
Right.
I think most people would call that tremendously successful. But if you have a really, really spicy meal, if you happen to be even just a little bit constipated and sort of being backed up a little bit, it's all plumbing. So you can have a little bit of a backup even with perfect plumbing. So in the TIF procedure, it's, if we look at the Nissen, that's extra normal, right? It's so tight that no reflux gets through, but at the same time, you have side effects.
Right.
And then you have normal people that don't have reflux, and then you have the TIF, and I kind of think of it, it's a little better than normal, right? That's kind of our goal. And normal people are going to tell you that, every now and then you're going to have some reflux here and there. That's pretty much, unfortunately, but that's pretty typical.
Yeah. So at what point should someone seek further treatment options if it's happening more than once a week, if it's happening every day? At what point Yeah.
Now, are you talking about the initial patient or a patient that's had surgery already?
Oh, no, initial patient.
Okay.
Initial patient. Yeah.
So, honestly, there's cases like Lori's where she had pneumonia. I mean, she started having recurrent pneumonias, and that's, I see a patient like her probably 2 or 3 times a year. I mean, that's not that uncommon. Of course, I treat reflux all day, every day, so maybe I see more than everyone else. But realistically, it's someone, if you've got those types of symptoms that are literally interfering with your health with regard to, ICU admissions or stuff like that, that becomes a pretty much a no-brainer. That's that needs to be evaluated. That needs something besides just pills. When you start talking about other disease processes, when you start talking about people that have bad esophagitis, if they've already been scoped by their GI doctor, then that's someone else that should really kind of be more pushed a little bit towards surgery, because that can go on and develop things like Barrett's esophagus that can be a precancerous condition. So that's something that I think needs to be more evaluated. As we keep going down the scale, realistically, in my opinion, anyone that either isn't satisfied with how they're doing on their proton pump inhibitor or is not really interested in taking these for the rest of their life can come in and get evaluated. And, it's not necessarily for everyone. We have a fairly lengthy discussion about the risks and benefits and how everything goes. And then we do testing. And if we can't find reflux, then obviously this may not be what's for you. So those are the types of patients we treat. And I've treated everyone from, people in their 80s that, are just miserable and having these pneumonias and things like that, or large hernias and they're having difficulty swallowing, to 20-year-olds that just got diagnosed with reflux that look at the rest of their life and like, I don't want to take these pills for the rest of my life.
Right.
So kind of the gamut.
Okay. Yeah. So we have some questions, more questions from our Facebook users. Someone's asking, I have LPR and I can't talk clearly, so is TIF right for me?
Yeah, LPR, it's laryngopharyngeal reflux, is a little bit tougher to diagnose. A lot of times, traditionally, we had people that would have symptoms somewhat similar to reflux, or with the speaking or swallowing, and it's hard to diagnose, and they couldn't find a whole lot. And it turns out that a lot of those patients have this. It isn't necessarily acidic. It isn't necessarily detectable on certain tests, and can be a little bit more difficult to manage. But I've been very successful if we kind of very carefully tease those patients out. If you are having laryngopharyngeal reflux from your stomach, this procedure works very well for that.
Perfect. Wonderful, wonderful. Now, Ambrose is asking, what is the longevity of the TIF procedure? Does it last forever, or will I need another procedure in the future?
So the quick answer is nothing in medicine is ever always or never. So that's the quick caveat. But realistically, the long-term data on TIF is extremely good. When they first started looking at it, they found that the people that had great results at 6 months still had good results at 1 year, and then they still had good results at 2 years. And then the follow-up study at 5 years basically showed that if you have a good result by the 6-month mark, you're still going to have a good result at 5 years. And in medicine, 5 years is kind of, we think of that as forever, because if it's there in 5 years, down the road, I can't tell you what it's going to look like in 30 years. But my experience has been that we've gone on and scoped these people later for different reasons, and the TIF still looks great. The hernia is still repaired, and most of them are doing extremely well. So realistically, I don't think they're going to need another procedure. Could they in the future? Maybe. The good news about that is, let's say it's 30 years down the road, the TIF procedure itself is actually very easy to repeat, versus a Nissen procedure, a redo hiatal hernia repair, very difficult. And that's something that the anatomy is extremely tricky, and lots of scar tissue, and lots of high-priced real estate in the area, including the aorta, the esophagus, the stomach, the spleen, vena cava, liver. All that stuff makes that surgery much riskier. Whereas, again, a repeat TIF procedure is relatively straightforward.
Yeah.
But hasn't been necessary. I've been doing this now for, I think, 8 years. I've been doing TIFs.
Right.
Gosh, like I said, I kind of had a couple in the beginning that we had to sort of repeat as the learning curve kind of grew. But I have not redone one in quite some time.
Wonderful. Thank you. Let's talk a little bit about the hospital stay, the actual day of the procedure, if you will. Maybe, Laura, you can talk about your perspective. You know, you went in, were you in the hospital? Did you stay there for one day? You know, what was the post-op like? What was post-surgery? And then maybe talk a little bit about your diet. I know you don't remember, it was a year ago and you slowly adhered to the protocol. And then Dr. Cottrell, maybe you can talk a little bit more about what your post-op protocol is.
Sure.
Yeah, Lori, from your perspective, what was it like?
I don't even remember what time I had the surgery, but probably late morning or so. I know when I woke up, the most painful part was the hiatal hernia scars.
Mm.
I don't know if I didn't feel the TIF at all, but honestly, I never felt like there was any pain or anything from that, even right after the surgery. It was, of course, you know, I had a few little scars, so that was painful, but I was up and walking by that evening.
Oh, wow. Okay.
Up and down the hall. So, not that I wanted to, but I was.
Yeah.
Really?
Yeah, and I did go home.
I
think I went home the next day.
Oh,
Next
okay.
day.
So, right, next
Next
day.
day.
Okay, fantastic. And then while you were there, were you taking I still after a couple, a week or two after, or were you strictly off your PPI?
I was off.
Off it. Oh, okay, fantastic.
There's a bit of a rebound phenomenon that can happen with PPIs where you're on them for so long and then you take them away, and then the cells that secrete the acid are sort of hypersecretory in that time frame, so you can produce more acid. Honestly, it's difficult to manage. We used to wean people off of their proton pump inhibitors. I'd do one every other day, and then we'd go one every third day. And I'll be honest with you, patients, it's just it was confusing. It got a little bit difficult. And to be honest with you, I for a couple patients in a row, we just said, let's just stop it and see what happens. Okay. And quite frankly, it went great. So I just stopped them that day.
Oh, wonderful. Okay. And then let's talk a little bit about diet. There's always a lot of questions about,
Sure.
Am I going to be able to bear the liquid diet for X amount of weeks? Can you
Sure.
share us? Yeah, Lori, what was your experience with the diet?
It really wasn't that bad.
Okay.
I was thinking it would be, but I'm not a big meat eater. I eat meat, but I'm not craving it. So, I do a lot of cream soup, that kind of thing early on.
Okay.
And that was fine. Fairly quickly, Dr. Cottrell can probably say exactly when, but I was able to move on to, I think it was called slippery things. So
Right.
any, pastas with sauce, that kind of thing. And once you can get to that point, there's a pretty good variety. And I really didn't have any issues with it. Every step I would take to the next thing, I had to be real careful that first swallow.
Right.
I could feel it, and I had to make sure I chewed enough, but that pretty quickly, when you could tell it, it must have stretched or whatever it was. I didn't have any issues at all.
Oh, fantastic. Yeah, Dr. Cottrell, do you want to talk a little bit about your post-op?
Yeah. So it's kind of funny, when we first started doing this, there's a really nice pamphlet that we used to give out that kind of went through like what you could have, what week, and all this. And I got to be honest with you, I threw it away because frankly, human nature is to find the loophole. And so it actually, the list generated for me in my practice generated more questions than it answered. And so basically what we talk about is right after surgery, and then when you go home, it's anything that could go through a straw.
That's good.
If it's in a cup and you can put a straw into it and suck it out, then you can have it. So that's the consistency. Consistency is the important part, not the food. The food, there's really no restrictions. So it's just the consistency. So straw-based foods, and that doesn't mean taking a long piece of spaghetti and go through a straw. It just means like kind of liquids, basically.
Right.
But what works really well, and I talk about this with patients because, early on, I just kind of, just was like, you figure it out. And, patients struggle with that. And so we've had I had a couple problems early on where patients really weren't getting enough protein, or they had, they just really got sick of dairy and yogurt and pudding and protein shakes or whatever. And so, things like blended soups work really, really well. So taking a canned soup, a good canned soup or a homemade soup, and then blending it basically fills the criteria and frankly still tastes good. So I've had a lot of sort of success managing patients that way. They seem to really like it. It's better. It's more variety. It actually tastes good as opposed to, you may like pudding more than anything on the planet, but after a while, pudding's gross, right? So anything, no matter what you eat, the same thing over and over again just gets tiring. And then, just like Lori said, usually it's a week to 2 weeks after surgery. You're seeing me, or I now have a PA that kind of helps me with this. And it's, how are you doing? Did you have any problems swallowing this last week? Were there any issues? And if there weren't, then we kind of move on to soft and slippery. So, things you could eat, and I like to keep it as simple as possible. Things you could eat without teeth, and if you couldn't make any spit. So it's got to be super, super slippery, and something that you can gum. So again, kids mac and cheese, that's a great example. Sauce, right? Not a baked pasta, but like stuff you would pour. So anything like that, and then like unblended soups is a good example too. And then that's the second stage, and then. And this is variable by every patient. So then we move on to what I just call soft and moist. And the soft and moist category is really a lot. That really opens it up to you can go out to eat with soft and moist and not really look weird or, having to make special changes. So soft and moist is anything you could gum and just not dry, because dry can kind of stick a little bit.
It's sticky, yeah.
Yeah. And then after that, then we move on to regular food. I make a lot of cautions towards bread. Bread sponges up, gets bigger, and it's super dry. So yeah, bread's kind of one of the last things. And even though a patient might be completely on a regular diet, they may still have some bread problems for just a little bit longer. And depending on the patient, that time frame is 4 to 6 weeks.
Okay.
Every now and then there's someone that's a little bit quicker and a little bit longer. But yeah, in the last 4 or 5 years, I can't think of anyone that we didn't get to regular food in a reasonable time frame. Okay,
fantastic. Is the healing time frame different if they've had a hiatal hernia repair as well?
Interestingly, a little, but not as much as you might think, because I do get patients like, gosh, I really hope it's not the hiatal hernia so we can just do the tip. And yes, the pain does get better quite a bit faster. You can walk around a little bit faster. The diet does progress a little bit faster as well. So there are definite advantages, but the hiatal hernia part of it doesn't add so much that it's unbearable, right? In terms of the significant pain, instead of like a day or two, it's like 3 days to a week, give or take. And again, everyone's widely variable.
Right.
And then, when you have either one, hiatal hernia repair or a TIF, we restrict lifting to 6 weeks. More than about 20 pounds. So the differences after a couple of weeks are pretty minimal, other than the diet's a little bit faster on the TIF. But the first week or so is definitely easier with the TIF.
Okay. When you mentioned restriction on lifting, are there any restrictions, if you're having the TIF procedure, just the TIF or TIF and hiatal hernia, are there restrictions as far as activities they can do? We got a lot of questions all the time, like, oh, I'm very active, I like to run or lift weights. What do you normally
depending on the patient, we talk about this a lot sometimes, because lifting or lifting equivalent. So that's my big thing. If you want to go run, great. As soon as you feel up to it, I have no issue with that. But sit-ups, push-ups, yoga, Pilates, anything where you're really having to strain, we really want to avoid. So oddly enough,
For how long normally?
6 weeks. 6 weeks.
Perfect. Thank you.
Yeah. So any kind of weightlifting, obviously, and groceries and things like that, we really want to have that be less than 20 pounds. People often ask about like stairs. Stairs are no problem.
Okay.
And like even Stairmaster, if you want to get up on the Stairmaster, that's not a problem. People ask, can I ride a bike? Yes, you can ride a bike. You can't lift it.
Good point.
Most bikes weigh more than 20 pounds.
Yeah.
Casual golfing is sometimes okay. It kind of depends on how hard they swing and how they're getting after it. Again, you can't lift the clubs. So anything that is sort of lifting. So like again, Stairmaster, treadmill, elliptical, all fine. Rowing machine, no, right? Because you're lifting.
Right. So we're getting another question. Someone's asking, Barbara's asking, I take Protonics in the AM, but I still have GERD sometimes at night. Wondering when I should actually be taking the Protonics. And then I also have a hiatal hernia, and I'm a type 2 diabetic. Does the diabetes factor in?
So they're taking what again? I apologize, I missed that first bit.
She's taking Protonics in the morning, and she still has GERD sometimes at night. She's wondering if she should be taking it, when she should be taking it, and
Right.
then the hiatal hernia, and then diabetes type 2. Does that have a factor?
Sure. The type 2 diabetes, we want that well controlled just from a general health perspective anyway, in terms of heart disease and everything that goes along with diabetes. But it does not really change how we approach this much. Diabetic patients are a little bit higher risk for something called gastroparesis that we have to be careful of. When the stomach doesn't empty properly, that can affect reflux, and it can affect our approach to reflux. So we do modify it if that's part of the symptoms. And that, again, that comes with the sort of the patient interview part of it. The hiatal hernia, no problem there. We can take care of that. The timing of the medication, honestly, the way that the half-life and the pharmacokinetics, or the way the drug gets metabolized by the body works, is that should be a 24-hour pill. Matter of fact, most people, when they stop taking it, they'll tell me that they don't really get symptoms until about 36 hours after. So if they have control on it. So taking it in the morning and then taking it and having symptoms at night probably just means that if you're taking the over-the-counter dose, the prescription strength is 2 over-the-counter pills. Or if you're taking a prescription strength, then it might be time to consider surgery, because now you're breaking through traditional therapy.
Right. Thank you. We do have one last comment, not a question, from Tara. She said, this is really great information. I'll be passing this on to my husband who suffers from GERD. So that's good.
Would not be the first time that I've had a spousal referral.
There you go. I'm sure that's probably how it always happens, right? It affects everybody. It's even your significant other, not just yourself. So the way you sleep, as you mentioned, activity. Yeah. Well, so, thank you guys so much for all of this great information, and Lori for sharing your story. Is there anything else that you wanted to leave us or say to the people watching the Facebook Live event today? Is there anything you want to recommend, or is there anything that you would recommend to them based on your experience?
Me?
Yeah.
I would say absolutely. I wish I had done it many years ago. But I had no idea it existed.
Right.
And I wish I had done it early enough that I could have recommended my father do it. He's too old for it now. But
right. Fantastic. Well, thank you.
That does bring up an interesting point. You hear that a lot. I get referred patients, or patients find me either from website or searches or something like this. And a lot of times they just didn't know.
Right.
They didn't know that there was another option. One of their primary care doctor, or they get treated on the medication works for a while, and then they have a self-doubt where sometimes they don't even talk to their primary care physicians. Like, well, I've already taken the pills and I'm still having symptoms, but be your own advocate. Definitely, if you're not doing well on a medication, please tell your physician. They want to know, they want to take care of you. And hopefully forums like this let you know that at least there's other options. And I tell people this all the time, whether it's patients or other doctors, come in, talk to me. I'm not here to talk you into surgery. I'm here to tell you what's available, to go through. And Lori could probably agree with you that what we just went through is a lot of what we talked about in that first interview anyway. And so you get all this information one-on-one. I draw, so you get to see that. And frankly, if it's not for you, listen, come back and see us later, or do what works for you. My job, as I've always seen it, is to provide patients with the best information so that they can make the best information that they can make for themselves.
That's awesome, and very well said. And the whole reason why we do our TIF Talks, because we want to make sure that those people out there suffering from GERD can learn more about what treatment options are available. And that's why we thank you guys both for being here, because the more that we can let people know about it, they can make some informed decisions for themselves. So again, I can't thank you enough, Lori, for being here, and Dr. Cottrell for you sharing. You are in the McKinney, Dallas, Fort Worth area. So if you are from that area, you can call Dr. Cottrell.
And I've treated patients from East Texas, Oklahoma, New Mexico. They've come kind of from far and wide.
There you go. And then if you're not obviously in Texas or outside of Texas, you can visit GERDhelp.com. That website gives you a lot more information about GERD treatment options and the TIF procedure. In addition to that, you can get on our physician finder and put in your zip code or your state, and you can find a TIF physician near you. So with that said, Dr. Cottrell, do you have any last final thoughts?
Well, I think my last comment kind of summed it up, so I'm feeling pretty good about it. I'll stand on that.
Perfect. Well, thank you again. And everybody that joined us tonight, thank you. We appreciate it. We have these TIF Talks every Tuesday, so join us next week for our next TIF Talk. Everybody have a great evening, and please stay safe. Thank you very much.